Welcome. I'm Nancy Maizels, Chair of the International Scientific Council of the Israel Cancer Research Fund, or ICRF. Since its founding in 1972, ICRF has been supporting the very best cancer research throughout the land of Israel. We've supported about 2,500 grants, totaling nearly $80 million so far. And currently, we're supporting 70 different investigators with about $5 million a year of total funding at the best research institutions and University of Israel. This is the 10th in a series of webinars that we began last spring in response to people becoming extremely curious about issues relevant to health and disease and eager to learn more about biology and medicine and hope for the future. And today's focus will be on cancer and pregnancy. I was surprised to learn that cancer is diagnosed in about 0.3%, that's 3 out of 1,000 pregnant women. And the frequency is expected to rise for a couple of reasons. First of all, more and more young people are being diagnosed with cancer. No one understands why. And second, women are bearing children later and later in life. I think most of us know this. So their chances of getting cancer increases. Most chemotherapies that are effective against cancer cannot be used to treat pregnant women because they pose dangers both for the woman and for the fetus. And there's some kinds of chemotherapy that can reduce fertility even when used to treat a woman who's not yet pregnant, but hopes to become pregnant in the future. These facts may make the topic of cancer and pregnancy seem like a truly odd choice for February, which the American Cancer Society designates as the month of hope. However, the work being done by our speakers today, Irit Ben-Aharon, gives us true hope that it may be possible to overcome some of the challenges that limit the treatment of cancer in women who are pregnant or hope to become pregnant. So now I'd like to tell you a little bit about Irit. Irit, are you on?
Hello.
Welcome to you. Thank you so much for joining us today. Irit is Director of Oncology at Rambam Health Care Center in Haifa. It's the largest cancer center in northern Israel, and it's part of Israel's premier institute of technology, the Technion. Irit is truly what we call a physician scientist. She received both an MD and a PhD degree in a joint program at Tel Aviv University and the US NIH. Her PhD was in developmental biology, and her oncology residency was at Rabin Medical Center in Petah Tikva. And then she was a Fulbright scholar at Memorial Sloan Kettering in New York City, where she studied gastrointestinal malignancies, GI we call them, and young onset cancer. In 2015, Irit returned to Israel and went back to where she trained at Rabin Medical Center. And then in 2018, she was appointed director of the Division of Oncology at Rambam. Irit publishes extensively, her expertise is internationally recognized, and she has a number of leadership roles in medicine in Israel. So today we're going to be truly fortunate because we get to see both aspects of Irit's life as a physician scientist, both in an interview with one of her patients and learning about the research in her laboratory. Irit.
So first of all, I'm very excited to be here, and thank you so much for the kind invitation. It's a great honor for me. Isabella was my patient we met 7 years ago, more than 7 years ago. She was diagnosed with stomach cancer. My main specialty is GI cancer, so stomach cancer is a main aspect of the GI tract. And she was diagnosed with actually an early stomach cancer. And the common treatment is chemotherapy followed by surgery and another course of chemotherapy. And before starting treatment, we advise the patients to have fertility preservation at least to have the discussion. Then they have to decide if they want to do that. We encourage that. And Isabella wanted very much to start chemotherapy because she wanted just to get over with this treatment and then with the surgery. And I insisted that she would go and discuss fertility preservation and do that and freeze the eggs. And
so
actually, I have.
Should we move now to hear it in her own words, do you think?
Yes, of
Great.
course. Hi, Isabella. It's great to see you. And thank you for joining us. How many years do we know each other? I think it's more than 7. It's a great celebration.
Actually, it's 7.5 years.
It's amazing. So, so we're meeting today because I am going to talk about cancer in young patients and fertility, pregnancy. And it's great that you can share with us your experience, your personal experience. Can you tell us about your cancer diagnosis and the conversation that you had about the effect of treatment on fertility?
Yes. First of all, thank you that you have me and choose me for this platform. I was diagnosed with, actually, I had a tumor in my stomach. It was endocarcinoma, and
it was a very early tumor in the stomach that you had.
Yes, it was in the early stage. It was a T2 N0, and it was in the early stage. I was the lucky one.
But we decided that you need to go for chemotherapy before the surgery, and then get chemotherapy after.
Yes, I had 3 rounds before, and then I had the surgery, and then 3 rounds afterwards. I have a gastrectomy of the stomach. 2/3 of my stomach was cut off, and it was very hard afterwards because there was a lot of side effects that I deal with them physically and emotionally.
And do you remember that conversation that we had before the chemotherapy about fertility? I remember that. That was more than 8 years ago, I think.
I remember that as well. I have to say that you brought it up because in that point in my life, all that I want, it was that I knew that I have a tumor. I want to get it out as soon as possible. I didn't think about the future. And until the point that you brought it up, I didn't think about it. I didn't think about children. I want to continue my life as they were. And I tell you that I don't want to do IVF. And actually, you convinced me. And you insist about it because you said that one day I will thank you for that, and the one day will come, and it comes.
And actually, we thought that it's kind of like a talk about the future, about the day after. I think
yes,
it's a very powerful talk.
It was a powerful talk because you give me hope. I could see the future in your eyes, and the meaning for me is it was that it's not all black, and I'm going to have a future. When the doctor talk about the future, the meaning of that is, wait a second, you're not going to die. You have a chance. So let's think about the future.
So what did you do following this conversation?
Actually, in this conversation, you do another thing. You recommend me about a good doctor. So I do an IVF with only 1 round IVF because you said that I have like 2 weeks for that. So I froze 10 eggs, and then we start the treatment, the chemo.
So we actually postponed the treatment a little bit, so you can prepare everything and your body can mature those eggs, and then those eggs were retrieved and frozen, and that was frozen, 10 eggs,
Correct.
and then you started the chemotherapy.
Yes.
And what happened next? I mean, you completed the chemotherapy and underwent the surgery and completed the adjuvant part of the chemotherapy, and then it was the stage of follow-up. So we met and you had all those exams, and later on, what happened with the fertility?
I have to wait. You know, there is a time, a safe zone. I have to wait a few years, and at some point I feel that the clock is ticking. So I didn't wait 5 years. I start to bothering you and ask you a question after 3, and you say, wait a little bit more, because the side effects of the chemo in my body was hard. I was very thin. I couldn't eat correctly. I couldn't feed myself. So I was very weak and very tired, and I had a lot of side effects. So first of all, I have to heal and to get weight and return to myself. But I have to say that the longing for a child and was something that in my bones, and you know about that because we spoke about it a few times, and I have to say that I was worried if I can get a pregnant, if I can carry a pregnant, if I can give birth a normal and healthy child, because I don't know if you all remember, but in some point I get to your office and I told you, okay, Irit, we have to see research. We have to find a research about women in my condition, if they had babies, healthy babies, because unfortunately, 7 years ago, there weren't a lot of women, young women, that had a tumor in the stomach. Yes, and I remember that I was in the net and in the books, and we tried to find something, but except some cases in Singapore and in Haifa, there wasn't a lot of research, and we decided to take a chance. You remember? And you tell me, why not? Let's see what can be happened. Well, a lot of can be happened, but the thought that I'm not going to be a mom was unbearable for me.
And eventually you use those eggs, right? Eventually.
Before we start the IVF, we do all the tests, and they say that I'm very, very fertile. The meaning of that is that I have a lot of eggs in my body. But after we start the rounds, I think that the quality of the eggs was very low. So after 3 rounds, the 3rd round, I use my fertile eggs, and I succeed in the 1st round.
So you use those eggs that you froze before the treatment, and then, and this is something that I have to show, I got this in my WhatsApp.
I'm in shock that you kept it.
I have it. So that is your first ultrasound or something that you can see the tiny baby here.
Now. Yeah. I'm in shock that you kept it.
I am. because I'm keeping that because I think it even for me as a doctor, it reminds me, this is what we are doing for this. I mean, we try to cure patients and then to give them the opportunity to go on. And I think that this is like,
now.
yeah.
I am emotional now because I have to say something. Most of the doctors want to treat the disease, but they don't see us as a whole. There is a person, there is Isabella, it's not a T2N0. And I'm not only a number. I'm
Definitely.
sorry, I catch a cold. I'm not only a number. And I have to say that you saw me, my needs. And you see, I don't know if you remember, but I had a breaking point. And it was the first round of chemo after the surgery. I was in a bad shape.
I remember.
And I send you a message in Shabbat. You are not working. I assume that you are going to see that in Sunday. But after 2 minutes after the SMS, you call me and you say, what? And what are you doing? Be with your family. And you say, okay, what is going on? And you speak with me. This is the meaning of doctor for me. You understand that it's not only important to saving lives, you understand the quality of life that young people like me need. Because when we are speaking about full life expectation of the society, full life, in my opinion, is to have a family, have children, get a mortgage, something that I can't do in Israel, have a car, go to vacation twice a year, and have a good job. And the most of the things patients, young patients that have a cancer don't have. And we have a lot of problems with sexuality, fertility, a lot of problems that doctors, they don't see. They think if you don't have a cancer, that's it. The job is done. And unfortunately, the job is not done. There is a side effects of cancer. It's terrible disease because all your life changed because of that. And I have to say that I'm grateful that you saw me and my needs, and you understand that I'm Isabella, first of all, and I'm Isabella that had cancer, but you could see me as a person that have disease, and you don't see only the disease. And it's something that I'm really, really, really grateful for that. And I'm feel blessed that you've been my doctor. Still now, you're my friend now, but you've been my doctor. And I feel blessed that you've been my doctor because you're young and you understand my needs. And I have a son because of you.
It's not because of me, but I think that what we did was
this
actually...
is Jonathan, and this is byproduct of your work. And if you are in that conversation, didn't convince me to do IVF, my son Jonathan wasn't here today. So I'm grateful for that. And for all of you, see us as a human being, as a name, Isabella, Tomer, John, and not as people that have only the disease. See our needs, our willing, our wishes, and that's it. And the people that dealing with what I deal in that point in my life, don't lose hope.
So thank you, Isabella, for sharing that message of hope with everyone. It's really moving to hear your story. and to see what an extraordinary impact Irit had on your life and your adorable son's life. And now I'd like to extend that message of hope by talking with Irit about the research that she's carrying out under her ICRF-funded project. And this is going to be very basic science, but basic science has been at the foundation of all of the major advances of medicine, and Irit's work is tremendously promising for its ability to identify ways to spare people some of the toxicities associated with chemotherapy. So I'd like to turn the floor over to you, Irit. Tell us about the research that you're carrying out.
So my current research is, as I said, about cancer during pregnancy. There is a lot of uncertainty regarding this topic. And if we talk about cancer during pregnancy, it is diagnosed in about 0.3% of the pregnancies, but it's the second most common cause of maternal death after gestational related vascular complications such as preeclampsia, other complications such as severe hypertension, etc. And the prevalence of cancer during pregnancy is expected to rise, especially in the Western world, due to the increase in average age at pregnancy, and also in part of the tumor types that we recognize in the last decade as increased among young adults. And the most common diagnoses are breast cancer, cervical cancer, lymphoma, ovarian cancer, and melanoma. But I have to say that today we see many types of cancer during pregnancy, and apparently it can arise at any site. And this is a main challenge, a main clinical challenge, because we don't have a lot of data regarding the mechanism of cancer during pregnancy and the side effects. And this is, for us as clinicians, a major unique clinical challenge because we must rely on very limited information with major decision-making. And there is a balance between the risk and the benefits for both the maternal and the fetal well-being, and this is something that we have to keep in mind. So it's not easy. And most of the clinical trials that we have on protocols, or treatment protocols, they exclude pregnant women, and therefore the effects of chemotherapy on the placenta and on the fetus are unclear. And when we look at placental vascular tree, this is an image in the left part. We can see the uterus in the non-pregnant woman, which has a lot of blood vessels, arteries, and veins. But in pregnant women, this compartment of the lining of the endometrium, internal lining, it becomes thicker, and the blood vessels proliferate over there in order to nourish the placenta and the fetus. And in our former work, we had a lot of data regarding the effect of chemotherapy on blood vessels and on the ovarian vessels and testicular vessels. And we saw that part of the mechanism of the damage that these chemotherapies may induce and the toxicity to those organs may derive from damage to the blood vessels. So we hypothesized that due to the fact that in the placenta there are many vessels, the placental vascular tree is huge, the effect of chemotherapy and those complications that may derive from the chemotherapy may actually derive from the acute direct toxicity to the placenta vascular tree, or to the very complex vascular structure of the placenta. And this is actually an image that we can see here in the blue right image, we can see this is actually a fluorescent image of the placenta. We can see the density of the vessels upon their color. But if we look at the diagram, we can see that the blood vessels actually become more and more thin from artery to arteriole to capillaries, which are the thinnest vessels. And these vessels actually, the whole vascular tree is comprised of those vessels. So we, in our work, had two models. One is a mouse model, and this is the main part of the project. And this has been done in collaboration with my colleague, Professor Ruti Shalgi from the Tel Aviv University. And what we did, we actually studied the effect of chemotherapy on pregnant mice. And later on, we also studying nowadays the effect on the embryos, on the offsprings from those exposed mice. And the second part of the work was a retrospective study in a cohort of cancer patients diagnosed in the clinic, diagnosed during pregnancy in the second and third trimester. And that was done in collaboration with my colleague Fedor Pecatori from Professor Pecatori from the Milan Institute of Oncology in Milan, in Italy, which is the largest center for pregnant women diagnosed with cancer. And we had a cohort of patients diagnosed during their pregnancy. And after their delivery, the placenta were collected and kept in pathology. And then we used those specimens in a retrospective study to study and to validate the mechanism that we saw in the mice.
So it might be good to distinguish the prospective studies in mice where you can do experiments. And in women, you can't do experiments, but there are lots of things you can learn from what's happened in the course of normal treatment. So that's a distinction I think many viewers don't appreciate. And it creates a difficulty that you have to think your way around when you address these problems. And you've done that beautifully, as we'll see. Yeah. So
yeah, so in women, we are very, very limited with what we can do. And moreover, if we, the aim of this study is actually to define the mechanism so we can develop protective measurements. So this is very limited as well later on if you want to have a clinical study and try to administer specific protectant agents to pregnant women. This is something that may be very, very challenging. But nowadays, what we are doing in the mouse platform, it's very easy to try and look for the mechanism, and then later on you can look for the blood flow dynamics, and you can look for the differences in the tissue, in the genomic profile. You can do many, many manipulations in the mice that, of course, you cannot do in the human, in the clinical setting. So actually, this is what we did in terms of the aspect of the blood flow. So we developed a real-time imaging platform to actually study at real time what happens to the blood vessels and to the blood flow of an organ. And we did it at first not in pregnant mice, but rather in normal mice. And we, in our initial work, looked for the effect on the ovarian vessels, and then we knew exactly how to characterize it. And later on, now we are doing that in the placental blood flow. So this platform is comprised of two machines. One is microscopic Doppler ultrasound, which enable us to really look for the blood flow at real time. We see exactly the dynamic of the blood flow of the placental vessels, like we can do to any other organ. And we can do that at real time. We can see exactly what is happening. And the other setting is a fluorescent confocal microscopy. It's a very nice, innovative imaging tool that enables us to really look for the structure of the blood vessels to see whether there is a leak following damage to the blood vessels, whether the blood vessel may diminish due to a specific trigger. And we will see that later on when I present the results. So actually what we did, the model was that a cohort, a group of mice, pregnant mice, were injected with either saline, that is control, salt solution, or chemotherapy. And we use doxorubicin, or the commercial name is adriamycin, which is the commonly used chemotherapy during pregnancy, especially for breast cancer, but also for lymphoma patients. And what we did is actually administer this chemotherapy or saline at the second trimester and follow those mice later on. So what we followed was the function of the placenta as a reservoir for the fetus. We looked for the fetal weight, for the placental weight, and for the ratio of blood flow between the fetal blood flow and the placenta blood flow. We also perform proteomics of those placenta that we retrieved following the delivery. And also we looked for the histology of the placenta to look for blood vessels to see whether there is any change in the content of the blood vessels, in their density, in their any structural aspect that we can see, the degree of proliferation of the placenta, and the degree of apoptosis, which is the natural death of the cells. So this is the tool that I described that enabled us to look for the structure of the blood vessels and the blood flow at real time. So what we did is actually injected the chemotherapy, and then we followed the dynamic of a specific segment of the blood vessels, of the placental blood vessels, and we looked at that following 10 or 15 minutes after the administration of the chemotherapy, and we also performed that in other control vessels. So it's not a unique feature of the placenta, but it happens in other types of blood vessels in the mouse. So what we can see actually is that following 10-15 minutes after the injection of chemotherapy, you can see here in white, this is the fluorescent signal of the blood flow and within the blood vessels. So we can see here, these are medium-sized blood vessels, and you can see there is disintegration of the vessel. It's not universal in all the vessels, but it appears in some of them. And you can actually see that in here, the signal is diminished. It means that the vessel is getting narrow and narrow until the blood flow is very disturbed over there. Mm-hmm. So this is one aspect that we saw, that there is an acute damage to the blood vessels following chemotherapy. So this is what we did in both the mice tissue that we had, but also in the tissue that we had from the placenta that we got from cancer patients, human cancer patients that were diagnosed with cancer during pregnancy. And after the delivery, the placenta was kept, and we had a cohort of cancer patients, and we had a matched cohort of chemo-naive not patients, but individuals, that women that got pregnant were at the same gestational week, but they didn't have any chemotherapy, and they were our controls. So what we saw in the mice resembled, and I didn't put in this slide the mice data because I wanted to emphasize on what we saw in the human samples. But we can see here that these are the treated patients, and these are the control ones. We can see that there is a different pattern of blood vessels in the exposed women compared with the non-exposed one. We can see more proliferation in the placenta of the exposed women compared with the non-exposed one, and we could see that there was more apoptosis, more cell death in the exposed placenta compared with the control one. So if I have to conclude this part of the work, is that vascular insult may contribute to chemotherapy-induced placental toxicity. We try to get deeper in this mechanism because understanding the role of vascular impairment may enable the application of protective measure that reduce the gestational complications in cancer patients. For example, if this damage involves a coagulant pathway, like we know from former studies that we had not in the pregnant model, but rather in what we did for fertility and gonadal toxicity, we saw that anticoagulants, such as low molecular weight heparin, for example, may reduce this toxicity. So this is an appealing tool, for example, to use in cancer patients who are pregnant, since this is a drug that is being supplied also for pregnancy, but also for cancer. So this is something that we are nowadays studying in our lab. And I think that if we elucidate this mechanism, we would have better chances of reducing these complications and maybe also affect the fetal outcomes as well. So I want to thank my colleagues, my team at my lab, Tal Goshen-Lago and Shiri Ashkenazi, and my students Orly Abramovich and Ruba Simian. And this work is a long-standing collaboration with Rudy Shalgi at the Sackler Faculty of Medicine in Tel Aviv University, Adas Bar Yosef and Anat Eldar Book, and my dear colleague Fedor Peccatori from Italy. And these are great guys to work with for several years.
It's wonderful that you have such a good team. So now I'd like to remind our audience that we know that some of these terms are not familiar, and we have a glossary on the website of terms if you wanted to put them into your little dictionary and feel that you've come away learning something that you could take elsewhere with you. And we aren't taking questions because we're recording this due to bad weather all over the US. But we know you may have questions, and I'm sure that Irit would be glad to answer them. If you email us, we'll relay them to her. And we did get a few questions. We've had help in preparing this from the ICRF staff and from wonderful ICRF board members. And they asked a few questions that I'd now like to address to Irit. This was really compelling, and I think everybody understands that addressing problems with blood flow could be a very fruitful area of research. But there were some more general questions about pregnancy and cancer that came up. So does pregnancy increase the chance of getting cancer? Has anyone looked at that?
So this is a very good question, and the question is very relevant, especially, for example, in breast cancer patients. that after they are cured, if they are young and they are interested in becoming pregnant, they ask whether the pregnancy may increase the chances of recurrence. So most of the studies, they don't show that. So most of the study, they don't present any increase in cancer due to pregnancy, not even in former breast cancer patients.
So that's tremendous.
That is very encouraging.
Very reassuring, very encouraging. So here's another question like that. Does cancer during pregnancy affect the fetus if there's no chemotherapy?
So that's also a very good question, because I would say that in most of the cases, when we don't treat the cancer during pregnancy, the lag between the cancer and the termination of the pregnancy is usually very, very limited, because we are very anxious to treat the cancer. So usually if the pregnancy is about to end, the gestational week is very progressive, then we can wait with the cancer and after the delivery to treat cancer. I don't think that there is a lot of data regarding that. There is very paucity of data regarding the effect of cancer itself on the fetus, but rather the effect of the treatment during pregnancy, because cancer cells, they would not pass through the placenta. So cancer itself would not affect the fetus.
So the last question is, what sorts of treatments could you imagine that would reverse the effects on the blood vessels that for the placenta, but not interfere with the overall effectiveness of chemotherapy? Is that a possibility?
Yeah, so actually we had several candidates upon the former study that we had not in the pregnancy setting, but rather in just general vascular toxicity. And we had several publications on the effect of anticoagulants to negate the effect of chemotherapy on the blood vessels, because we saw that this disintegration of the blood vessels, it elicits the coagulation pathway, and maybe a drug like Clexane, like low molecular weight heparin, or we also used some of the drugs that are being used in cardiology. We saw that it may reduce the vascular toxicity of the drugs. So in the pregnancy setting, it is more challenging, because you cannot use any drug because of this safety issue to the fetus. But there are some, since hypercoagulation is also a very relevant in the pregnancy setting, we use that now as a protective agent. We investigate that. So that is very appealing because it's very safe in pregnancy.
That's great. So now, would you want to spend just a minute talking bigger picture about cancer in the young before we have to say goodbye? I know we could talk all morning, but or all evening, but we can't do that. So say a few words about this bigger question. Yeah,
so apparently what we see in the last decade is an increase in some of the malignancies. I have to say that most of this increase is in the GI tract malignancies. So there is a substantial increase in colorectal cancer in young patients below the age of 50 and even below the age of 30. We can see also in gastric cancer, esophageal cancer. It's very, very disturbing because we don't know why, and it's not genetic, it's not in the hereditary in most of the cases, but we see this increase. And this poses many challenges to the clinical setting that we didn't have in the past in this extent. So we have a lot of these unmet needs. Part of them are psychosocial, but part of them is are medical. So we're talking about all those late-term toxicities such as fertility, such as cardiovascular. As I mentioned in the beginning, these patients that may be cured from cancer but may have vascular pathologies, hypertension later on, myocardial infarction. We don't have any guidelines to administer protective measurements because we don't know the mechanism. We know that we follow the oncological aspects, but we sometimes lack the right follow-up to see the other systems. And when we get the events, it's probably too late.
So your work on blood flow gives us a lot of hope that these other questions can be answered by basic research coupled with clinical investigation. So maybe this is a good place for us to end. First of all, thank you, Irit, and thank you, Isabella in Israel, for participating. And I'd also like to thank everybody on the ICRF staff who's helped get the webinar together and up and running, and to thank the ICRF board members who provided their wonderful insights. And most of all, I'd like to thank our wonderful audience who we'd like to point you to the ICRF website where you can learn more about our webinars, more about ICRF's work. And we're also happy to announce that next month we'll hear more about gastrointestinal cancers and how they can be treated perioperatively by Shamgar Ben-Aliyahu, who's at Tel Aviv University and has a separate ICRF project going on this topic. So thank you to everybody. This has truly inspired me, and I hope it's inspired a lot of people. Thank you again, Irit.
I want to thank you also, and also thank the ICRF. I think it really gives the opportunity to get the next step of cancer research, but not only cancer research, but we see that there is cancer, but there is the life after cancer. So we need to take care of that also.
Good.
Thank you so much.